EKG of the week. Let's look at another EKG and try to pick out the salient points of it. Again, just as an FYI, I sort of started to do this as a teaching aid for our paramedic class. And this is folks that just started to learn about how to read an EKG. So some of the early ones are sort of based on that. This one is a common morphology that you'll see, but that we haven't really talked about so far. Again, as always, take a minute, look at the thing, and pause the video, really, kind of analyze it, go through the algorithm, and then come back when you've got it interpreted. Okay, let's take a look at this EKG. So, as always, we'll start with rate, and as I've kind of mentioned before, I prefer to just count the number of complexes on the page because it's a 10-second strip, and so I can just count that, multiply by 6 to get the number in a minute. So if we look here, there's kind of half one, but let's just say 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. 17 complexes times 6 gives you 42, if I remember correctly, and that looks about right. If we looked at the space between each beats, these are pretty regular, so you could try to do that. Let's see. So if we went to here, one big box gives you a rate of 300, two big boxes 150, three big boxes, which right about there, maybe a shade under, maybe a little faster, gives you right around 100, and so that'll equal out for both sides. So okay, it seems about right. We'll call this a rate about 100, truly a rate of about 102. And I'm going to hold off on putting the text up here for just a second because we need to look at rhythm, and I'll cover up the rhythm strip if we don't do that. When we look at rhythm, we say, is there a P wave? Does it fall before each QRS complex? And does every QRS complex seem to follow a P wave in an appropriate fashion? And it looks like there is, as we look across these long strips at the bottom. And you don't have to look at the long strips at the bottom. You can look at the top, P wave, P wave, P before QRS, QRS following each P. This looks like a sinus rhythm. So we've got a rate at 102, or roundabouts 100, but we'll call it 102, and sinus rhythm. Maybe sinus tach, it's right over 100, but we'll call it sinus rhythm. Rate rhythm axis, again, if you had to skip axis, you're not going to hurt my feelings, but just to say that we did it, we are up in 1, which means electrical activity is traveling from the right side to the left side of the body, and we are we'll call it isoelectric, maybe a little more up in AVF, meaning it's probably perpendicular thereabouts to AVF, which is going to put it in the good side. It's going to put it kind of at that almost along the along lead 1, which is what you kind of see here. It's almost entirely positive in lead 1. Long story short, that is a normal axis, and we'll just leave it at that. Rate rhythm axis intervals and blocks, those come in here. So let's look at each interval here, and we'll get a little tighter on it. This is a good spot to look at our individual intervals. If we look at the PR segment, that's supposed to be smaller than one big box, and it looks like it is on that tracing. If you look at our QRS complex, or our PR interval is okay. If you look at our QRS complex, it is supposed to be under 3 little boxes, which is a little tough to tell on that one. Maybe we can go over to this one. It looks like it is well under 3 little boxes, and we can confirm that in another lead here too. Looks like 1, 2 boxes, 2 little boxes gets it done. All right, so QRS complex, that interval is okay, and I'll just include these all together. When we look at the QT interval, which looks like a good place to do kind of right here, again, you can look at the computer, and that's the best way to get a true reading on it. But the T wave is supposed to be done before you get halfway between the R to R interval, or the QRS complexes. So if we looked at, get back to the pointer here. If you look, there's an R wave, or this little R wave, and there's a little R wave right there. And is the T wave done by the time it gets about halfway there? It's pretty close. It's a little tough to tell, but it doesn't look like this is a severely prolonged QT interval to me. So I don't see any intraventricular blocks per se. I don't see any AV blocks or anything like that. So intervals and blocks, we don't see any of those. rate, rhythm, axis, intervals, and blocks. Ischemia and infarcts. Let's look for ischemia. Well, let's look for infarcts first, or STEMIs rather. And as I scroll through here, no big ST elevation, no big ST elevation, looking for greater than a millimeter. Don't see it, don't see it, don't see it. I'm going to scan down through the V leads, the precordial leads. No significant elevation, tiny bit of elevation there, but again, in the V2 and V3, you expect some elevation. And if we just kind of scroll on over here, don't see it. Now let's look for ischemia, i.e. ST depression and T-wave inversions. Just to give you the rundown of it, didn't see a whole lot of those either. What did you see out in V6? You may say like, well, there's some ST depression there. And if you look at the TP segment going into it, yeah, maybe there's a little bit of ST depression. There is a flipped over T-wave, certainly. And you may say, well, okay, maybe that's lateral ischemia. And, you know, we could say that maybe it is, but I am just thinking that it's probably not. The reason I'm thinking that it's not is that I think that this change over here, this bit of ST depression, this little bit, and the T-wave change, I think is due to this giant QRS complex that you see here. So when you have the QRS going one direction and it's really big, then usually the ST segment and the T-wave, sometimes the T-wave, but at least the ST segment often will kind of follow that. If you think of like our left bundle branch block, it would be almost abnormal. Well, it would certainly be abnormal to have an ST segment that's going the same direction or moving the same direction as the QRS complex. And those are big QRS complexes. So I'm going to say that, you know, maybe this is a little ischemia out here, but I doubt it. I think this is more probably due to this gigantic QRS complex here that goes all the way up and, you know, gets in the middle of the complex above it. And likewise, V5 does the same thing, which we'll get to in just a second. Because now we're going to talk about patterns. So the most obvious pattern is that thing that we see here, these giant QRS complexes. What do you see when you think about big QRS complexes? Well, usually we're taught that that's left ventricular hypertrophy, or LVH, which is probably the case in this person most likely. Again, don't know any clinical history. This is just an EKG that we found. But this is a good example of a QRS complex reaching up and touching the complex above it. Likewise, if you look at these guys, the QRS here goes down, that S wave goes down and touches the complexes in the next strip. That's sort of a poor man's like, this is probably LVH. Now, if the heart is right up against the wall of the chest, sometimes you can get these big old complexes, or in young males or skinny folks, you can maybe see that, but this is pretty pronounced. The other reason I think that this is probably left ventricular hypertrophy kind of pattern, and there are some things, by the way, that you can apply to it, but I can never remember them. But the other thing that kind of makes me think that is if you look back and looking at some other patterns, when you look back at the P waves over here, we don't usually look at how P waves look, except if we're looking for atrial enlargement. Why would your atria get enlarged? Well, if you had a big stiff ventricle, i.e. LVH, or left ventricular hypertrophy, then as blood has a hard time getting into it, it backs up into the ventricle, into the atria, and that causes the atria, which is thin and stretchy, to get dilated out. So if you've got a big if you've got a big hypertrophic, poorly relaxing left ventricle with LVH, then you might expect to see some atrial enlargement behind it. And in fact, if we look at our atria, i.e. the P wave, we see in lead 2 down here, we see this big, almost as big as the QRS complex, big upright P wave here. And that's, usually P wave is this little tiny thing. But that is a big old, probably right atrial enlargement sort of looking P wave. Likewise, if we look at V1, where we normally will look at for like the left atria, if you remember the criteria or what a left atrial enlargement looks like, it is usually this negative, again, big negative P wave, or it can be a biphasic P wave, usually not the little upright thing that we're used to seeing, that looks something like that. So either a predominantly negative or mostly negative big old P wave here, or a biphasic P wave suggests left atrial enlargement. And again, that would make sense. You have blood backing up from a poorly dilating or poorly relaxing, rather, ventricle, and so it backs up and fills up the atria, and the atria gets big. So I'm going to say that this pattern looks like a biatrial enlargement. The right atrium and the left atrium are both look enlarged. And it looks like that's probably due to some LVH, which we see with these big patterns down here. So I'm going to call it that. Again, I don't know, there's no clinical anything on this. This is just an EKG, but that's what I'm going to call it. And so our impression overall, we have like mild sinus tach, maybe mostly sinus rhythm, maybe a T-wave inversion in V6, but I think it's more due probably to LVH, and that goes with the finding of biatrial enlargement. So hopefully this is helpful. If you have any questions, let us know in the comments or send us an email, and we'll see you on the next one.